Good afternoon. Welcome to our first lung and heart-lung transplant virtual town hall. My name is Elyse Elconin-Goldberg. I am 7 years post a double lung transplant. Along with my co-chair, Bob Duffy, the patients and medical staff on the Lung and Heart-Lung Patient Family Advisory Council, we are thrilled that you are all joining us today for this very informative event. Our Patient Family Advisory Council's goal is to make the patient experience at the Lung and Heart-Lung Transplant Clinic the best possible. Through our two past informative-filled newsletters that I hope you all received, to the wonderful education day that we had in 2019, our PFAC wishes to continue to provide ways to reach out to our fellow patient population. I would like to thank Sarah Foad, the manager of volunteer services, for helping us today with technical support to make this virtual town hall a success. Without further ado, I would like to introduce my wonderful co-chair, Bob Duffy.
Hi, everyone. Thanks, Elyse. Yes, I am indeed Bob Duffy. I'm one of the co-chairs of the PFAC, and I am a double lung transplant recipient now a little more than 3 years post. I'd like to add my own welcome to everyone logging in today, and we hope you're as excited about this initial online town hall as we are. And we hope you find this session informative and helpful and are looking forward to it as much as Elyse and I both are. I'd like to introduce and welcome our three speakers today. Many of you are probably very familiar with them. First, we have Dr. Gundeep Dhillon, head of the Heart and Heart-Lung Transplant Program here at Stanford. Joining Dr. Dillon will be Dr. Yelizaveta Sher, Clinical Associate Professor, Psychiatry and Behavioral Sciences, and Dr. Joanna Nelson, Clinical Assistant Professor, Medicine and Infectious Diseases. And now I'd like to turn the virtual podium over to Dr. Dillon.
Thank you everyone for joining, and thank you Bob and Elyse, and I want to thank Sarah for helping us arrange this town hall. You know, in October of 2019, we actually had done our first lung transplant annual teaching day, which I thought went very well, and that was also arranged by our wonderful PFAC and Elyse and Bob with their input. At that time, we didn't realize that we won't be able to do that in 2020 for obvious reasons. So in lieu of that, I'm very thankful to everyone for arranging for this town hall, and we want to take this opportunity to give you an update on the program, give you an update on the COVID-related issues with pre and post lung transplant, including vaccination status as far as we know. So again, thank you everyone for joining. So I'm gonna go ahead and give just a programmatic update. So the things which have happened since that education day in October 2019, and then we'll be able to answer questions at the end of the three presentations. I'm gonna go ahead and share my screen. So these are the things I wanted to kind of give you an update on. Obviously, our number one asset for the program, other than our wonderful patients, is our team. And I just will give an update on our team. Since our last meeting, we did move into new hospital, which is not that new anymore. We moved into it around Thanksgiving of 2019. So I just want to give an update on that. You know, there have been a few changes in our clinic workflows related to the pandemic, and then just give you an update on where we stand as far as our volumes go, and some of our benchmarking reporting as reported by UNOS, and then what we have been able to complete as far as quality projects, lung transplant quality projects are concerned in 2020, and what are we planning to do further for the next year or for this 2021. So as far as our team updates go, thankfully there haven't been too much turnover in our team. So the number of most of our pulmonologists, transplant surgeons are the same. We do have 5 APPs, and thanks to Stanford Healthcare, we are waiting to hire one more nurse practitioner, and we have been able to recruit, I believe, a very strong candidate, and she'll be starting in February. We continue to have 2 pre-transplant coordinators. We did have some turnover on our post-transplant coordinators, as you know. Lindsay has, because of her own family reasons, and commute-related issues, had taken another job in San Francisco. But we are actively recruiting for her replacement, as well as, again, we have approval, but just because of the growth of the program, we have an approval for another transplant coordinator. So we'll be up to 5 post-transplant coordinators, which I think we need, and hopefully it'll be helpful for everyone, and we'll be able to improve our access for patients to our coordinators. And then we have, again, 2 pharmacists, which are all of you are very familiar with, our wonderful social workers and dietitians. We have been able to increase the number of our patient care coordinators to 3 from 2, and that they are the ones who are actually doing a lot of work as far as coordinating clinic visits and appointments and setting up various procedures. And then finally, we have new program manager. She is going to join us today, but I don't think she's online right now, Julia. And we are very happy to have her as a part of our team. As far as the hospital and clinic updates go, like I said, we moved into the new hospital back in around Thanksgiving of 2019. And at that time, the vision was that all of the M6, which is the M unit on 6th floor, is going to be all lung transplant or advanced lung disease. And it has worked out pretty well, but unfortunately, because of COVID pandemic and our census, COVID-related census, currently the unit is being used to house our COVID patients. So we are in a little bit of a flex situation here, but I do not expect it for sure. Once we are past this pandemic, we'll, M6 gonna be home for our, transplant program. And all our fresh transplants go to the unit next door, which is J6, and we use the J2 and J4 ICUs. And, these numbers may or may not mean much to you, but we are very fortunate that we have been able to get very, for lack of a better word, prime real estate in the new hospital for our advanced lung disease and lung transplant program. As far as clinic updates go, again, we have talked for a long time about doing video, offering telemedicine and doing video visits for our, both pre and post lung transplant recipients. And pandemic obviously forced our hand. And for a while, in our early last year, we were doing majority of our clinic visits as video visits, but currently we are down to about 10 to 15% of all our clinic visits are being done over the videos. And we expect to maintain that number going forward. So we do want to offer that opportunity or that convenience to all our patients. But having said that, obviously there are some downsides to those visits, as far as, so that's what I envision, that we'll do somewhere in 10 to 20% of our visits going forward will be video visits, and we expect that to continue even past pandemic. Again, to improve access, we are starting a new clinic. As most of you know, we do clinic 5 days a week, Monday through Friday, and in the mornings. And again, because of recent growth in our program, clinic access has become an issue. So we are starting this clinic, which will be predominantly staffed by our wonderful nurse practitioners, and it'll be on the Friday afternoons. And as far as, again, some of these changes were again related to pandemic. Just to reduce the amount of time everyone is spending in waiting rooms, we are not doing, most of our pulmonary function tests are being done in room, so that people are not spending time in the waiting room and getting exposed to other folks. And we do realize that the blood draw stations, at least at the main campus, have become a major issue. And we are actively looking into see if we can have phlebotomists come to rooms once people are roomed, rather than them having to go to the blood draw stations. And then with Dr. Nelson's help, we have been able to start a transplant ID clinic, which has been going on for about a year now. So every first and third Thursdays of the month, we have this combined transplant infectious disease clinic, which from my perspective has been very successful, and I hope everyone finds convenient. The people who have to go to both transplant and ID clinics are finding it useful. As far as the number of transplants, in spite of the pandemic, this is the biggest. 2020 was the biggest year we have had as far as transplant volumes go. We did overall 67 transplants, out of which 59 were lung transplants and another 8 were heart-lung transplants. As far as heart-lung transplants go, we continue to be the largest program in the country. We do anywhere from 20 to 25% of all heart-lung transplants, which are done in the US every year. And only other thing I was going to say, in 2020, obviously, we did our first post-COVID related lung disease transplant. So far we have done 1 post-COVID transplant, and I think nationwide there have been about 15 transplants for COVID-related lung disease. And as far as the benchmarking go, the only thing I wanted to show that as far as, one of the markers we look at a lot for quality is how long patients are staying in hospital after transplant. And this is just one example, and we are right there. So our median length of stay after transplant is 16 days, while nationally that number is 18 days. And for our region is 16 days. So I think both our region and our program are doing well as far as the lengths of stay are concerned, our post-transplant course is concerned. And this is it's a busy slide, but this is just a summary of the projects we have worked on and have completed in this past year. A lot of credit goes to Zainab Chulu, who most of you haven't met, but she's our quality manager, and she's the force behind making sure we are performing at the highest level possible. And this is a slide I borrowed from her. So we did work a lot on our survival outcomes, which is always an ongoing process. We did work on our lengths of stay, which I do think have been successful. With the CT surgery and ICU teams, we have come up with this support, because there was one big problem we felt in management of our patients in the ICU, the surgical pain management guidelines. And one of the things we have worked with outside agencies, both local rehab hospitals at Kindred and Kentfield, which are in the Bay Area, for our patients who need rehab services either before or after transplant. We have spent a lot of time developing these relationships so that the care between different places is streamlined. And then we continue to work very closely with Donor Network West, which is the organ procurement agency for our area, just to making sure that all our potential donors are being managed optimally, and that we have access to all the donors. And work with them about improving donation rates in our region. And I think a lot of these have been very successful. We are very proud of the work everybody has done. And some of the projects we have planned for coming year, one of the things we have heard some feedback on is our discharge processes, that some of the discharges have been less than smooth, and a lot of especially fresh transplants are discharged and have to come back for things which probably could have been prevented with a better discharge planning. So that's one project where and Julia is working on process mapping, that how we discharge people and identify the areas where we could do better. And then the other one, which I want to point out, which I'm very excited about, Dr. Josh Mooney, who a lot of you know is taking a lead on this. We really want to develop the M6 floor of the new hospital as a truly an advanced lung disease center, for lack of a better word, where it becomes almost like a one-stop shopping, where even whether the patients are our patients as far as lung transplant program or just people with advanced lung conditions primarily get admitted, and where they get a very comprehensive evaluation, whether it's use of the nebulizers, whether their nutrition, their rehab, so that everything is kind of at one place. And we are really working, and Dr. Mooney and his team has been working very hard on developing those processes. And I'm very hopeful that after pandemic, we'll be able to implement those once we get our floor back. And Bob had already introduced Dr. Nelson and Dr. Sher, so I'm gonna hand over the rest of the talk to them. And Dr. Nelson is gonna talk is primarily focused on COVID related issues and vaccination issues. Thank you.
Thanks, Dr. Dillon. Let me just take a minute to share my screen.
I have to, I think,
Unshare first.
I stopped sharing.
Thanks. Sorry, one second. Okay, can you guys see my slides?
Yes.
Okay. So I first want to just thank Dr. Dillon and the PFAC committee for having me today. I could definitely talk about this for hours. So this is not necessarily comprehensive, but trying to target some of the questions that we got before today, and just highlight some of the things that I thought might be of most of greatest interest to this group. Okay, so going to be kind of focusing on two things. First of all, you know, COVID in the setting of solid organ transplant, kind of how we think about this disease in this patient population a little differently, or you know, how it manifests differently potentially. And then secondly, talking a little bit about vaccinations, since I know that's kind of forefront on everybody's mind appropriately right now. So this is just a timeline of illness that I thought was helpful in terms of a framework to think about COVID in the transplant population. So having been on, you know, taking care of people in the COVID unit, this is kind of how we see this manifest every day. So you can see in the beginning, at symptom onset, this is kind of typically the time in your system where you have active viral replication. So you're starting, people are starting to feel those kind of viral symptoms: cough, fever, sore throat, maybe some GI upset. And then as the disease progresses, some people develop this post-acute hyperinflammatory illness where you have immune dysregulation. And a lot of times, and this occurs around week 2 of the illness. And a lot of times this is when people start to feel shortness of breath. And it's likely a manifestation of this immune response, dysregulation of the immune response for patients. And then further out, which we know a lot less about, is this potential for late sequelae, which I'm not really gonna talk much about today. We need to learn a lot more about this. But I think what's interesting in the solid organ transplant population is that this second phase of this post-acute hyperinflammatory illness might appear very differently in people on immunosuppression. So I think that might color kind of how we see this disease manifest for solid organ transplant patients. So there have been a few studies kind of trying to characterize this, and we still definitely have a lot to learn. But just to highlight a few, so University of Washington is kind of recording cases and having people submit cases to kind of come up with this multi-centered database so we can look at larger numbers of solid organ transplant patients who have had COVID. Apart from this cohort in the US, a lot of what has been published is single center studies, which I'll talk about kind of pros and cons of some of the information that comes out of that. So at any rate, so far the largest cohort, what they've reported is about 500 patients from over 50 transplant centers. I know that since then they have gotten a lot more patients, I think on the order of 1,000. So they'll likely be reporting some more information in the future. Out of solid organ transplant patients who were positive for COVID, the median age in their study was 58 years old. And most patients, the median time from transplant was about 5 years. 61% of patients were male, which I think kind of correlates with the overall slightly male predominance of this disease. And greater than 90% had at least one additional comorbidity, which I'll touch on in a minute. You can see the breakdown of solid organ transplants. So most were kidney, followed by liver, heart, and then lung. 6% of that number of 482 is about 30 patients. So still not super high numbers here, but something to get us started. But I guess it's a good thing we don't have super high numbers, but. So in terms of outcomes, this is one of the questions that came up. In previously reported studies, outcomes in the solid organ transplant population have been very variable, with mortality rates listed anywhere from like 7 to 50%. So clearly that's a wide range. I think this is just, what's been reported so far and why there's such variability is kind of just been, it's reflected of the pandemic. A lot of the studies that are out there are single center studies, so you're getting a snapshot of what's been going on in that area. So you're kind of limited by the amount of follow-up people have had, limited by the geography, and also by a rapidly changing landscape and management. So just to give an example, some of the, initially when the pandemic epicenter was in New York, clearly they had the largest number of cases. So a lot of this reported data was coming up from there. It was also a time of a very resource, they were under a lot of resource strain. And I think that probably factored into, how patients did. So their mortality rates, were higher at the time than we were seeing here. And then secondly, it's been since March that we've been dealing with this pandemic, and things have evolved over that time frame. So in the beginning, a lot of people were trying to give hydroxychloroquine and azithromycin. And now we have some, we know that those things don't work and are maybe even potentially harmful. And we've, developed some other antivirals and anti-inflammatory treatments that can be helpful. And, at least with things like steroids, improve mortality. So clearly that can change kind of the landscape of outcomes that you're seeing. So just going back to that larger cohort study that was reported in the fall. So they overall found that out of their cohort, 31% of solid organ transplants required mechanical ventilation, and they reported a 20% mortality. Now, those are numbers that are higher than, I would say the non-transplant population, if if you're comparing, although that's not what their study was doing, it was more a descriptive study. They did find, however, that it's probably a lot more complicated than just saying, do you have a transplant or do you not, in terms of your outcomes. They found that really it was people with underlying comorbidities that did have this associated increase in mortality. So things that we know in the non-transplant population that are put people at increased risk for severe disease as well, such as age greater than 65, congestive heart failure, chronic lung disease. And this is lung disease kind of over and above, if you've had a lung transplant and have good lung function, you wouldn't necessarily fall into this category. It's somebody who, has some chronic lung disease kind of on top of that, and obesity, all being comorbidities which were associated with increasing mortality. And they looked at kind of levels of immunosuppression intensity in multiple different ways and didn't necessarily find those things were associated with increased mortality. So although we kind of approach the solid organ transplant population as potentially having greater, potential for greater severe disease, they didn't necessarily find that immunosuppression in and of itself was associated with worse outcomes. And this may be kind of related to going back to that timeline, how the hyperimmune response is one of the things that leads to severe disease for people. So it may be that this is kind of, that's kind of truncated in somebody on immunosuppression. Similarly, this is just briefly from a study that I felt like did a good job controlling for all those confounders like comorbidities or things outside just having a transplant in terms of trying to compare outcomes for people. So it's another multi-center study of patients who were only admitted to the ICU, so already at, the intensive care unit, so already had a severe level of disease. And they compared solid organ transplant patients to non-solid organ transplant patients. And they overall found that if they controlled for all those comorbidities and other factors, that the outcomes were similar between groups, such as the number of people on mechanical ventilation, the number of people who developed significant lung injury, and the number of people who died. So I think that we still have so much to learn. And what we know in terms of what's out there in the country and being reported, and that we talk about with various providers, is that certainly we know the effect viral infections can have on solid organ transplant patients. So we do have an increased level of concern for this infection in people, but it's probably a lot more complicated than that. And it may be that because this immune response, hyperimmune response and immune dysregulation is such a factor in the severity of COVID that, being on some level of immunosuppression might not be such a bad thing. Okay, so hopefully that was somewhat helpful and not too confusing. Switching gears a little bit to vaccination. So this is from the Washington Post. There's a few of these out there just in terms of vaccine trackers to give you kind of a sense of where we're at overall. So currently there's 12 vaccines in phase 3 trials and 2 vaccines, as I'm sure we're all very aware, that have been approved via emergency use from the FDA, the Moderna vaccine and the Pfizer vaccine. So I was just going to talk a little bit about these two, and kind of how they got approved and the efficacy and safety. So both of these have been approved via emergency use authorization from the FDA, both in December. They're both mRNA vaccines, so not live virus. Basically, mRNA is kind of like a instruction manual or guidebook that kind of gets into cells and will tell the cells how to make a particular protein that is found in the virus. And then it allows the immune system to kind of mount a response to that protein. There aren't currently any approved mRNA vaccines in use, but this modality has been studied a lot for various infectious diseases and cancers in the past. So, overall felt to be pretty safe. The Pfizer vaccine is 2 doses that are given 21 days apart, and the Moderna vaccine is 2 doses 28 days apart. Overall, there were over 70,000 participants in these phase 3 trials. So kind of lumping the results together, they were found to have a 94.1 to 95% efficacy in preventing infection. So Moderna was 94.1 and Pfizer was 95% in their study. And I guess it's important to realize that this was tested at a time point 7 to 14 days after the second dose. So you know that at that time point, they're very efficacious. They did show that even earlier in the course, for example, like 12 days after the first Pfizer dose, you do see some mounted immune response, but you're not going to be, as protected as you are about 7 to 14 days after the second dose. So it's still certainly possible to get breakthrough infection even after that time point, or especially in the early time point as your body is mounting an immune response. The safety profiles for both, which were studied over 2 months, were very favorable. And overall, it's felt that, really majority of side effects that you see from vaccinations are within this time frame. The most common side effects were injection site pain, fatigue, and headache, which were greatest after the second dose. The efficacy appears similar in patients older, than 65 years of age compared to younger patients. I just mentioned this because we're going to talk about some of the shortfalls in terms of interpreting this vaccination in the setting of solid organ transplant. In general, people older than 65 years have a weaker immune system than younger people. So in a way, this is promising to see that people older than 65 did have a good immune response to this vaccination, suggesting it's fairly immunogenic. Out of the breakthrough infections that were seen in the studies, the breakthrough infection was generally mild. So this is also a good thing to see in that the vaccine can prevent development of disease, but also if you do develop disease, likely have a milder phenotype than somebody who's not vaccinated. And then lastly, the durability of vaccine titers isn't really known at this point. We need further studying to look at this. Currently, it appears that they last for at least 4 months' time. So how about in solid organ transplants? So unfortunately, we have no data really to go on here in terms of efficacy and safety in this patient population. As we know with other vaccinations, it's certainly possible that somebody who's on immunosuppression may have decreased immunogenicity to the vaccine. In terms of timing of vaccination, the recommendation would be similar to other vaccines after solid organ transplant. So ideally given at least 2 weeks prior to transplant if you're somebody who's pre-transplant, or somewhere in the realm of 1 to 6 months after transplant in order to have the most robust immune response and hopefully protect you from the disease. There's no data really for this vaccine specifically in terms of whether or not you need to worry about it precipitating rejection. But I think in general, overall, now the thought is that based on some data for other vaccinations, that this risk is very, very low, that experts basically feel like this is unlikely to precipitate rejection. Weighing everything, likely a safe thing for patients with solid organ transplant to get. It's also important to realize that if somebody previously had COVID, it's still recommended at this point that they get vaccinated. And I think for a solid organ transplant patient, probably even more importantly, knowing that, immunogenicity or lasting titers from the illness itself might also be something that's difficult to mount in the setting of immunosuppression. And another caveat of the vaccine, not necessarily specific to solid organ transplant patients, is that it's unclear if the vaccine can prevent asymptomatic disease or spread, because really these studies were looking for symptomatic presence or absence of symptomatic disease. So this is something we'll probably learn in the future. So I think overall, in terms of what is being recommended for solid organ transplant patients, and what I would tell people is it's really about weighing, risks and benefits for you. A lot of this slide is taken from the American Society of Transplantation site, and they have some good FAQs on there. But I think it kind of depends on, you're weighing potential benefit versus potential risk. And I would say that, the potential risks seem fairly low with the vaccine, and the potential benefit, especially if you're in a place where there's a lot of spread currently, which is unfortunately where we're at now, likely outweighs the risk. But it's difficult in the setting of a somewhat data-free zone, so may end up being very individualized discussion with people. And I know there was a lot of questions about logistics of the vaccine rollout, which I apologize, I'm somewhat in the dark there with you. But this is, as I'm sure everybody's seen, what the Advisory Committee on Immunization Practices are suggesting in terms of tiers of rollout for the vaccine. So currently we're working locally on this 1A phase, which is healthcare personnel and long-term care facility residents. 1B would be other frontline essential workers and persons age greater than 75. And then 1C are, the 65 to 74 year age range, and then people who are younger who have high risk medical conditions, which is where somebody who's immunosuppressed with a solid organ transplant would fall. This is what's recommended on a level of, federal advice. And certainly this can be altered by local public health officials. Looking at the California guidance, it seems to mirror this right now. I think that there's not, because it's kind of unclear how long it's going to take to get through each of these phases and what the supply will be and how quickly things will move. I think we don't know a whole lot about when it will become available to the following tiers. But I know that, the Quality Council that Gundeep mentioned previously is working on, the best way to make it available to our solid organ transplant patient population, and we definitely will keep you abreast of anything as we learn more about it. So that's kind of all I have to talk about. I'm happy to take questions later.
All right, well, thank you so much for having me here as well. I know that there's a lot of important questions, which also, about the vaccines and so forth, which would be important for addressing the mental health as well. But I wanted to quickly just say a few words in terms of mental health in the times of pandemic. So I think we're all aware that, of course, on top of the COVID-19 pandemic, we also are going through mental health pandemic related to it right now. And it's not surprising, right? Especially for people who already live with chronic medical conditions, such as being pre or post-transplant. Now there's additional stress of the pandemic, of isolation and restrictions associated with that. There's also, of course, other triggers and challenges that we have faced, especially in California, the fires, right? There's the political environment. There are financial considerations that come together with the pandemic. Loss of jobs, and then the existential crisis that also goes along with it. That's real at this time. So we know that the rates of the depression and anxiety disorders have certainly been high, right? And in some studies, approximately 20 to 30% of people who've been surveyed in a variety of situations at this point are experiencing depression, and up to 40% of people are experiencing a variety of anxiety disorders. And the risk factors include female gender, prior psychiatric disease, chronic medical condition, which is of course an additional risk factor, living in an urban area, and actually also being a healthcare provider as well. So this is just important to realize. So what can we all do with this, right? Kind of as we're dealing through this, and at this point, right, 10 months in, many of us are experts, but it doesn't mean that it's easier to deal with this ongoing situation. So first of all, just a few kind of quick, coping tools that I think many of you probably have already discovered, but I just wanted to remind you of those. First of all, I think it's often just important to realize that we're not living in normal times. So whatever emotions you're experiencing, fear, anxiety, frustration, irritability, depression, it's normal, right? It might not be healthy or helpful, does not feel good, but it's a normal response to a very abnormal situation. And sometimes just reminding yourself that this is not what we're living through and your feelings are really valid is important to kind of take a break and validate yourself. But despite
I think we may have lost audio and visual for Dr. Sher. So in the meantime, why don't we move on to some questions? So I will invite Drs. Nelson and Dillon to rejoin us here, and we can move into some questions that we've received during our session today. So we got a lot of questions about COVID, of course, prompted by Dr. Nelson's great presentation. So I'm going to run through some of them here. When should Stanford transplant patients expect to be offered the vaccine? Are they considered higher risk, or will they be lumped in with the general population?
So I think that transplant patients will probably be, still part of that first phase. They are considered higher risk because of their immunosuppression. I don't really know in terms of timing. I don't know if Gundeep, you know any better than I do, but I think that we will, certainly on our minds as much as yours. So you'll definitely be hearing more from the team when it becomes available.
Yeah, so I don't have any more insight as far as the timing is concerned. There was a question whether we will advocate for our patient. Of course we will. And, and they have formed Stanford Hospital has formed a task force, just to kind of try to prioritize our own patients, because obviously every group, every team appropriately are advocating for their own patients. So there is actually a work group to do that. But as far as I do think, our recipients who are over 65 will fall in tier 1B anyways, just because of their age. And then almost everyone, all of our patients or our transplant recipients will fall in 1C for sure, because that goes from age 16 to 49 or higher, just because of their immunosuppressed status or the fact that they had transplant. So I think everybody will fall in phase 1C, but when it kind of kicks in, that I don't have that much clarity on that yet.
Thank you. And Dr. Sher, I see you rejoined us. Why don't we just go through some of the final questions here, and then we'll turn it back over to you.
Sounds great.
Thank you. Okay, so next question. Does mRNA alter our DNA? I still don't quite understand mRNA and the long-term effects.
Yeah, good question. It doesn't actually alter our DNA. It doesn't, the DNA is something found in the nucleus of your cells, and mRNA does not enter into that. So it really is kind of like a guidebook for the cell to make this particular protein that mirrors a protein we see in COVID. And then that protein is displayed on immune cells, and your other immune cells can see it and kind of mount a immune response to that. So it's not altering your genetic material in any way. And
that mRNA gets degraded after a little while, so doesn't become part of the permanent part of this genome or cells.
Thank you.
Great, thank you for the clarity. Next question, what is the mask protocol after I receive my vaccine? And will I be okay to be around people that are not vaccinated?
That's a great question, and thank you for asking that. So right now, it's recommended that really you stick with the same masking protocol after you get the vaccine as we're doing now. And that's because, as I mentioned, we don't really know what the vaccine does for asymptomatic infection. That wasn't studied in the studies. So we know that it decreases symptomatic infection and that it decreases severity of symptomatic infection, but we don't know what it does with asymptomatic spread. So it's still going to be recommended that you stick to the same kind of social distance guidelines and masking guidelines until we have a large enough number of people in the population vaccinated.
Great, thank you. Next question. Will people be able to choose which vaccine they get? I'm not so concerned about Pfizer versus Moderna, but I know there are other vaccines coming that are not as effective.
I do not know the answer to that.
Yeah, it's a hard one. And it's my understanding, at least on the staff side, that we likely will not be able to choose kind of whatever's available to us.
Yeah.
Next question. What are some steps being taken to include transplant patients in higher tiers for the vaccination?
Sorry, can you ask that one again?
Sure. What are some steps being taken to include transplant patients in higher tiers for the vaccination?
Okay. Well, I think mirroring what what Dr. Dillon said before is that, based on age and transplant status, you're going to be at least 1B or 1C in terms of tiers. And like he said, the team will be advocating ongoing to make sure patients can get it, but I don't know about kind of jumping up tiers other than that.
Thank you. And one last question before we turn it back over to Dr. Sher. Part of my medication regime is azithromycin. Is this something that should be looked at again to pause until we get through the pandemic? Or is the half-life not so much that if I were to contract COVID, it wouldn't be an issue?
So I'm gonna, hopefully I answer this correctly. So this azithromycin was looked at to see if it was helpful for treatment of COVID, and it doesn't necessarily help outcomes in COVID. But unlike hydroxychloroquine, or at least if you're not using it in that combination, it's not necessarily harmful either. So if you need azithromycin for your other medical issues, then I think it's fine to be on it and continue it if you do, unfortunately, contract COVID, if that answers it, hopefully.
Great. Thank you so much. We did get some other questions, but that's all the time we have today. So actually, one last question that has come in repeatedly, I apologize, is will we have to be revaccinated every 4 months?
So I think that we don't know the answer to that yet. So far, studies have shown that the titers last for at least that long, but we don't really know how long they last. So it may be that booster vaccination is needed, but I think we need more data to determine what the optimal timing of that would be.
Great. Thank you so much. And I will pass it back over to Dr. Sher.
Great, thank you. Well, I guess I'm back. I think our virtual connections are wonderful and sort of a maybe silver lining, right? One of the silver linings of this pandemic, but obviously they can still malfunction, and we just have to keep going with the flow. So we're talking about, self-care is very important coping tool, right? Always that we all have to deal with what's going on right now. And it's taking care of ourselves physically, taking care of ourselves emotionally and psychologically, whatever that means for you, and also taking care of yourself spiritually, again, whatever that means for you. So really paying attention to those spheres of your life. Creating new transitions during this time that unfortunately potentially have been forced on us, but then also realizing and capitalizing on those can be really important, right? I think actually I've heard, holidays might have been difficult for many people, but also I've heard from a lot of people that in a way it was nice to have quiet holidays and just to enjoy either being with the small group of loved ones or to even just have the day to yourself. So just appreciating whatever it is, the new traditions that we are right now creating for ourselves. Going along with that is also creating boundaries, right? Really finding out what works and what doesn't, right? Probably listening to news 24/7 is not helpful. So really getting away from that and maybe just dedicating, I don't know if it's possible these days, but 10 to 15 minutes of news per day, if that. Getting rid maybe of social media, right? Or even of anything that's not working right now, right? So just really being very clear with your own boundaries of what's working for you, for your emotional health versus not. Mindfulness, right? The idea of being mindful and in the moment, right? We should not, and go many places these days, so right? So just really being mindful, whatever it is that we're doing, right? Cooking meals, eating, exercising, right? Watching a show, reading a book, whatever it is that we're doing, just really being present in the moment can actually create a lot of contentment and joy. And reaching out to whatever forms of supports you have, right? Friends, family, healthcare providers, peer support groups, realizing that those connections are there and using them in ways that are safe and helpful. Something else that can be really helpful is meaning making, right? This is a traumatic time, but there's also a lot of post-traumatic growth that happens with that. So making meaning out of this time, again, whatever that means for you, maybe for some people it is helping helping others, growing yourself, just realizing what's important for you right now. But meaning making can be a very helpful concept. And then, of course, right, reaching out for professional help. The good thing is that, you know, now we're virtually, mental health providers are virtually available. It's sort of forced, right? Forced this telepsychiatry. And while it's not exactly the same as being in, you know, kind of in 3D with your mental health provider, but definitely you don't need to go anywhere, right? It's so much easier to connect if you do need to therapists, social work, or psychiatrists, so reaching out to those supports. So reach out, and the best way, if that's something that you're looking for yourself, obviously working with your PCP or your insurance company, or reaching out to the transplant team, right? The coordinators and social workers and myself, and we can definitely help and make sure that you are connected with the provider that you can work with. So that's all that I have for today. Thank you so much.
Great, thank you so much. I'm going to pass it back over to Elyse and Bob to close us out for the day.
Thank you, Dr. Dillon, Dr. Sher, and Dr. Nelson. I am sure I speak for the whole group that we are so appreciative of your presence today. We are also looking forward to having future virtual town halls and hope that all of you who attended today will again join us. I'd also like to thank Sarah Fohad for her incredible technical support. Additionally, Bob is going to put our Patient Family Advisory Council email address in the chat, and we welcome comments and suggestions for future topics that you would like to see presented. We hope everyone stays healthy and safe in this new year. Until we meet again, I'd like to thank everyone for joining us today, and have a great rest of your weekend. Bye.